Welcome back to Ask Dr. Mingle. It's great to see you again. I'm Dr. Dan Mingle, family physician, founder, and CEO of Mingle Health. I'm here to answer your questions about value-based care and value-based payment. Let's dig in. Today's topic, the 2026 final rule for the Medicare physician fee schedule, including those things that I'm interested in and will be speaking about. Medicare Shared Savings Program, the Quality Payment Program, including MIPS, that is the Merit-Based Incentive Payment System, MIPS Value Pathways, alternative payment models. Today's presentation is focusing on MIPS. I've previously done one on summarizing the final rule and giving you an introduction to the annual rulemaking process. And subsequent presentations will include APMs, MIPS value pathways, the Medicare Shared Savings Program, and the new model, ambulatory specialty model. Now, the final rule was released October 31st of 2025. Some rules are retroactive to the 2025 performance year. I'll call them out as I present them, and most go into effect January 1st, 2026. If you want a little bit more reading, a good summary that's well written, well organized, I'd recommend this QPP fact sheet and comparison table. It lays out the previous rules and the new rules side by side so you know how they changed. Medicare produces it. You can get it through the link that's built into the title of this page if you access the slides, or you can find it at qpp.cms.gov on the resource library. Just look for regulatory productions. It's alongside the final rule and some other summaries and announcements of various. As Medicare reviews the performance to date on each of their final rules, this year was no exception. They explained that 2024 is the 8th year of the quality payment program. 2024 is the most recent year that we've completed, submitted data, had it calculated, and we're facing the adjustments based on that 2024 performance year in this coming 2026 year. 2026, of course, is the 10th year of the quality payment program. 94% of eligible clinicians participated in 2024. Now, it's interesting. I would expect about 6%, well, let me say 3% of providers to retire every year. So the amount of people who didn't participate is roughly equivalent to those who would be expect to retire in a 2-year period from 2024 to 2026, since it takes 2 years for that performance score to turn into a payment adjustment. Now, of those participants, 87% were queued for a positive payment adjustment, where only 13% were at zero or negative adjustments for the year. That's one of the reasons why we never see large adjustments. These scores are weighted enough to the good side, to high scores, that very few are in the negative adjustment range. And it's the negative adjustments that create the pool of money to pay to those with positive adjustments. And it's only that amount of money that changes hands, because these programs are, by legislation, revenue neutral. Now, in contrast, of those few that are on the losing side of the equation, some lost as much as 9% of their Medicare book of business. That's a real loss, typically suffered by those who don't make any efforts at submission, although a very low score can do that as well. So in this year, the key thresholds: the performance threshold, which is the score at which, above that score, you get a positive adjustment. Below that score, you get a negative adjustment. That's held steady in this new rule through 2028 at 75. It's been 75 for the last several years. The data completeness threshold, previously set at 75%, through the 2028 performance year hasn't changed. Now, both of these are subject to change in any rulemaking cycle. They are setting rules to last through at least 2028. So I don't expect changes to happen with this sooner than that. But if there's good reason, Medicare, again, can't change that in a single rules cycle. Scoring category weights are the same. They've been now for several years, 30 for quality, 30 for cost, 25% for promoting interoperability, and 15% for improvement activities. So they're subject to circumstances that call for reweighting, such as special status of practices, some practices who routinely are not responsible for promoting interoperability. APM participants don't get scored on cost. Extreme and uncontrollable circumstances can either be automatic, depending on how large the scope of the event, or based on application. If something simply happened to your practice that kept you from participating in one or all of the activities. In the quality performance category, the usual up and down of measures, there are 5 new measures, including 2 new ECQMs. 10 measures were removed. There's substantial changes to 30. 3 of the measures in that 190 measure inventory are exclusive to MVPs. That's mixed value pathways. And there are over 1,000 potential QCDR measures, but those are maintained in a separate mechanism and aren't included in Medicare's final rule. Reference to health equity has been removed from the high priority measure definition. They're no longer considering efforts at health equity to be high priority. There's been a change in topped-out measures. I think year by year we're seeing some more fiddling with the topped-out measure policies. This year it's focused on specialties who don't have enough measure choice. So those measures that Medicare is considering necessary to maintain enough measures for various specialties are no longer going to be subject to the 7-point maximum topped-out scoring. That kept those scores down for those specialties who were suffering already from a lack of measures. Now they're using the whole scale of potential scores from 0 to 10. But they're compressing it into the high end of the scale. And here on this page is a table showing those point distributions. So you have to score 84 points to get onto the scale at that 1 to 1.9 available points level, which stretches up to 10 points if you have a 100% performance score. 19 measures have qualified for this scoring for the 2026 year. The list is here. I'll give you a moment to read through this, or you can access the slides to read through them at your own leisure. They're also changing administrative claims measures scoring. You may recall for 2025, the final rule for 2025 created a new scoring system for cost measures. Now that just went into production in the 2025 performance year. They're proposing to do administrative claims measures with the same techniques also for the 2025 performance year. So over those 2 final rules are bringing both cost measures and administrative claims measures into the same technique. Both are calculated by Medicare. You don't make any submissions for this. Both are scored on performance year benchmarks. The median scores have been as benchmarks. A decile-based benchmark is mathematically supposed to come out with a median score around 5, spreading out through the whole decile range. But it compares unfavorably to the scoring for quality and the composite score for MIPS, in which 75 has been set as the midpoint of the scale, as that performance threshold, above which you get a positive adjustment below which you get a negative adjustment. Cost and administrative claims measures typically, on the average, have always brought scores down. So the average of the composite being 75 and the average of the cost and administrative claims measures being in the 5 range, which correlates to 50, you could see that typically brings it down. They're changing that by matching the means and distributing up and down, not by the decile, but by standard deviations. And I'll show you that here. Here's an example. This is the scoring intention. Changing from that decile based to standard deviation based. The median is set here at 7.5, so you get a 0 score. You get a 7.5 score at the median of whatever measures being measured, and then they go up and down by standard deviations in this schedule as you range from the 1 to a 10 score range. So you won't experience typically these scores pulling your composite score down from now on. This is an example they gave us last year from the cost measures. These administrative claims will act in the same way. I've illustrated the old scoring on the second and third columns, new scoring in the fourth, fifth, and sixth columns. Pulled out 2 numbers for you to look at. The green number is the average cost of a screening colonoscopy in that year. The average cost in the old scoring gave you a 5-point score. In the new scoring, it will give you a 7.5 score. Now, if you move into showing a high cost, for example, 1,126, that gave you a score of 1.9 in the old style, but gives you a score of 5.5 in the new style. So moved everything up. Now, it's not so true for the really good scores. It's compressed those more. You don't necessarily get more help from those higher scores. But again, overall, most of us will experience an improvement of our scores overall from this change. Now, CAPS for MIPS, also considered a quality measure. Remember that registration deadline if you want to participate in CAPS for MIPS. That deadline is June 30th annually. They've added a web-based survey mode starting with a 2027 performance year, and demanding a protocol that goes from a web-based survey with follow-up of mail survey for those who don't respond to the web, and follow up a phone survey for those who don't respond to mail. And they're also requiring that Spanish language translation be offered to those who communicate in the Spanish language. Moving on to the cost performance category, there are no new cost measures. There are 35 cost measures still in the inventory. They've introduced a 2-year information-only status for new cost measures. There are revisions finalized for the total per capita cost measure, that's TPCC. A little change in how they define the candidate event and attribution criteria, finding that 2 primary care visits trigger to attribution. The first visit is a primary care E&M code by a primary care provider. The second service is another primary care E&M code or primary care service that is provided by a primary care provider in the same tax ID number group as the first service. Now, non-physician practitioners visits, and this is important, as it reduces the over-attribution to non-physician providers, are excluded if all the physicians in the practice in which those non-physician providers are reporting are excluded by specialty. So once there's attribution, the next 12 months of costs attribute to the practice. And for every new trigger pair, it goes on for the 12 months after that trigger pair. So it can go indefinitely for someone who's regularly getting care in one practice. It can be limited to just 1 year if they just get those two services and never have another trigger event. A few interesting adjustments to the promoting interoperability performance category. First, the security risk analysis measure continues as before, but now it's required to also conduct security risk management as indicated by the analysis. And a yes is required on both attestations to earn any score in promoting interoperability. Safer Guide requirement has just been updated for the newest version of the Safer Guide that came out in 2025. Again, just the high priorities unit. They're adding a new public health and clinical data exchange objective for optional bonus points, and that's public health reporting using the TEFCA infrastructure. That's a national infrastructure that one submission can serve as a clinical data exchange option. And they've developed a new measure suppression policy, and specifically applying it to the electronic case reporting for 2025 because the CDC had to suspend their implementation of this as they make some infrastructure upgrades. So now you still need to report that to get credit for it, but basically there's wide leeway for answering that question, which is on hold for the year. Improvement activities, again, the typical changes, 3 new measures, modify 7, remove 8 for a total of 109 measures in the 2026 inventory. They're removing the Achieving Health Equity subcategory in performance activities and removal of related activities, and instead replacing it with an Advancing Health and Wellness subcategory with options under it. So that's my rundown of the rules. Submit any questions, ask for more clarifications. The places to comment and submit are here on this slide. Correct my answers, contribute your comments. We are smarter together. Thanks.